Hello, and welcome to the Open Anesthesia POCUS Case of the Month, August 2025. Let's start with a clinical case. A 66-year-old woman with a past medical history of hypertension, diabetes, obesity, and end-stage renal disease who was recently dialyzed via central venous catheter 2 days ago, undergoes an uncomplicated laparoscopic peritoneal dialysis catheter placement. In the PACU, she developed worsening dyspnea and increased oxygen needs. Her vital signs are as follows: temperature of 36.8, heart rate of 98, blood pressure 142/78, and a respiratory rate of 24. She's saturating 91% on 6 liters nasal cannula. To structure our discussion of the patient's lung ultrasound evaluation, we'll use a helpful mnemonic that has been proposed to guide interrogation of diagnostic point-of-care ultrasound into routine clinical care. The mnemonic is IAIM, which stands for Indication, Acquisition, Interpretation, and Medical Decision-Making. The lung ultrasound examination was performed to help narrow the differential diagnosis of the patient's hypoxemia. Due to the patient's discomfort and abdominal pain following the procedure, the ultrasound examination was limited to the anterior lung zones. A sector array transducer was positioned near the patient's midclavicular line between the second and fourth intercostal spaces, oriented in the parasagittal plane with the probe indicator directed cephalad. For this examination, each view will first be evaluated independently, then integrated to form a cohesive overall impression. Let's begin by examining the individual views. Now let's take a look at our patient's ultrasound. This image is obtained from the patient's right anterior chest. Shown here is a representative clip of the patient's right anterior lung field. Which of the following best describes the sonographic findings in this image? A, an A-line profile, B, a B-line profile, or C, a Z-line profile? Correct answer is B, a B-line profile. A-lines are horizontal echogenic lines that appear at regular intervals below the pleural line. They are reverberation artifacts created when the ultrasound beam reflects repeatedly between the pleural surface and the transducer in the presence of air-filled alveoli. Because air is a strong reflector of ultrasound, these reflections generate bright, evenly spaced horizontal lines that run parallel to the pleural line. A-lines are typically seen in well-aerated lung tissue and are considered normal finding, but only when accompanied by lung sliding. Lung sliding confirms that the pleural layers are intact and moving, which rules out pneumothorax at that location. Without lung sliding, A-lines alone may be seen in cases of pneumothorax, where the pleural surfaces are no longer opposed. It's important to remember that A-lines are not specific to healthy lung alone. They may appear in patients with obstructive lung diseases such as COPD or asthma, where lung aeration is preserved. B-lines are vertical hyperechoic reverberation artifacts that originate from the pleural line. They represent an interaction of ultrasound waves with fluid-filled or thickened interlobular septa within the lung parenchyma. They extend from the pleural line all the way down to the bottom of the screen, typically at least 15 centimeters, without fading. They move in synchrony with lung sliding, confirming their origin from the pleural line. B-lines typically obliterate or obscure A-lines, where the two intersect as they interfere with normal reverberation artifacts caused by air-laden lung. We will now briefly review simplified physics of B-lines and expand on the definition of B-lines. The generation of B-lines is most commonly attributed to ring-down artifact, a form of reverberation artifact. This occurs when ultrasound waves become trapped and repeatedly reflect between structures with markedly different acoustic properties. In the lungs, this typically happens when air-filled alveoli surround fluid, thickened, or fibrotic interlobular septa. These tissue-dense or fluid-filled regions create acoustic traps that give rise to continuous reverberations. One proposed mechanism is that when fluid becomes trapped within a tetrahedral configuration of air bubbles, the ultrasound waves reflect infinitely within this microstructure, generating a persistent vertical echogenic line. In the accompanying diagram, visually illustrates this phenomenon. As ultrasound beams encounter a droplet of fluid surrounded by air-filled alveoli, the trapped energy produces a series of delayed echoes. These echoes are interpreted by the machine as an infinitely repeating signal, resulting in a bright vertical artifact that emanates from the pleural line and extends to the bottom of the screen, what we recognize as a beeline. Z-lines are vertical artifacts that originate from the pleural line but are generally short, dissipating within 2 to 4 centimeters, and never reaching the bottom of the screen. Unlike B-lines, Z-lines are ill-defined, fainter, and less echogenic. They do not move along with lung sliding and do not obliterate the underlying A-lines. Z-lines are considered a benign artifact and hold no clinical significance. They are commonly seen in normal lungs. In contrast, B-lines are pathologically relevant when numerous, as they may indicate interstitial syndrome. Recognizing these distinctions is essential to avoid overinterpreting normal findings as abnormal. Now let's return to our patient and review the sonographic findings and interrogate the available data to formulate a comprehensive clinical impression. On lung ultrasound examination, the patient demonstrates a bilateral B-line profile, with more than 3 discrete B-lines identified in each intercostal space across multiple lung zones on both the right and left sides. The diffuse distribution of B-lines is indicative of an underlying interstitial syndrome. When interpreted in an appropriate clinical context, such a pattern, particularly when symmetrically distributed, strongly supports the diagnosis of pulmonary edema, most commonly of cardiac origin. In this patient, who presents with orthopnea, the interrogation of cardiac ultrasound findings demonstrating left ventricular hypertrophy and a dilated IVC further supports this etiology. Taken together with the patient's history of end-stage renal disease, the most likely diagnosis is volume overload due to diastolic dysfunction or an acute decompensation of heart failure. Let us now explore how the anesthesia team effectively integrated lung ultrasound findings into their clinical decision-making process. With the aid of lung ultrasound, the anesthesia team was able to rapidly narrow the differential diagnosis to acute pulmonary edema. The sonographic findings played a pivotal role in guiding the timely clinical decision-making, prompting initiation of non-invasive positive pressure ventilation and emergent dialysis for volume removal. This targeted intervention resulted in a prompt resolution of the patient's symptoms. When bilateral B-lines are observed on lung ultrasound, they indicate the presence of increased lung water or thickening of the interstitial tissue. However, the underlying causes can vary significantly, making it essential to consider the clinical context. Broadly, the differential diagnosis includes hydrostatic causes such as congestive heart failure or negative pressure pulmonary edema. These conditions occur when elevated hydrostatic pressures lead to alveolar flooding. On the other hand, non-hydrostatic pulmonary edema results from increased capillary permeability. This category includes conditions like acute respiratory distress syndrome, preeclampsia, or transfusion-related acute lung injury, where inflammation or injury to the endothelial cells is a key factor. We also must take into account chronic interstitial processes, such as pulmonary fibrosis, which can present with diffuse B-lines due to thickening of the interlobular septa. When evaluating for interstitial lung disease or pulmonary fibrosis, both clinical history and ultrasound findings play critical roles in raising diagnostic suspicion. Patients often present with a chronic and progressive course characterized by fatigue, exertional dyspnea, and persistent non-productive cough. These symptoms typically evolve gradually over time. On lung ultrasound, several characteristic features may be observed, most notably diffuse B lines, often bilateral and extending across multiple lung zones. These are reflected in thickened interlobular septa due to fibrotic or inflammatory changes. Additionally, the pleural line may appear irregular or thickened, a finding that supports the underlying structural distortion of the lung parenchyma. You may also identify subpleural consolidations, which are typically small patchy areas of increased density near the pleural surface. These suggest localized areas of fibrosis or inflammation. When combined, these sonographic features, interpreted within the appropriate clinical context, can help differentiate ILD from other causes of interstitial syndrome, such as pulmonary edema. When assessing pneumonia through lung ultrasound, it is essential to take into account the clinical context of the patient. Common presenting symptoms include fever, cough, and dyspnea. The following sonographic findings are suggestive of pneumonia. Unilateral B lines. These findings are particularly significant when they are restricted to a single lung zone. In instances of multifocal or bilateral pneumonia, as often observed with viral infections, B lines may be evident bilaterally. Subpleural consolidations. These consolidations typically present as hypoechoic, irregular areas that are adjacent to the pleural line. Dynamic air bronchograms. This characteristic reflects air movement within the consolidated, non-aerated lung tissue and serves as a crucial differentiator from atelectasis. Lung hepatization. This phenomenon occurs to a dense inflammatory infiltration, causing lung parenchyma to assume echotexture resembling that of liver tissue. Interpreting these ultrasound findings in conjunction with the patient's clinical presentation can significantly enhance the diagnostic accuracy of pneumonia at the bedside setting. Sonographically, ARDS may exhibit a diffuse B-line pattern, often similar to that seen in cardiogenic pulmonary edema. However, ultrasound alone cannot reliably distinguish between these two entities. Thus, clinical context, including timing, precipitating factors, and accompanying hemodynamic findings, is essential for accurate diagnosis. In the setting of pneumonia, or ARDS, due to an underlying infectious etiology, the B' profile, characterized by diffuse B lines with absent lung sliding, is more indicative of alveolar interstitial syndrome related to inflammation rather than cardiogenic pulmonary edema. The absence of lung sliding in this context suggests pleural inflammation or adhesion commonly seen in pneumonia and ARDS. Interpreting B lines requires integration of both clinical and sonographic context to ensure diagnostic accuracy. Several key factors must be considered. First, assess the distribution of B lines. Are they diffuse or focal, unilateral or bilateral? This distinction can offer valuable clues, such as diffuse bilateral B lines suggesting cardiogenic pulmonary edema, while focal or asymmetric patterns may indicate pneumonia. Next, evaluate quantity. More than 3 B lines per intercostal space in a given zone is generally considered pathological and suggests an interstitial process. Examine the pleural findings closely. Pleural thickening, irregularities, or the presence of subpleural consolidations may help differentiate between etiologies like pulmonary fibrosis, ARDS, or infection. Finally, always interpret ultrasound findings in the light of the clinical history, including symptom duration, acuity, and comorbidities, as these are essential for distinguishing between similar ultrasound appearances arising from very different pathologies. Some references inform the content of this presentation. Thank you so much for listening.